Hello, everyone. Welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist trained at Duke University, practicing in South Florida, Broward North. I am the APD for Fellowship Program. I'm also the chair for antibiotic stewardship for the district, and I do medical directorship position for infection control. Teaching is one of my it's very rewarding to see and teach the residents and fellows. This Zooming Through ID is a short, focused teaching session where the residents and fellows, they take ownership of learning. So each presenter will be assigned a topic, or they pick a topic of interest, and they do a literature review. And then they get to teach us in this session. And it's not just about the facts, but because it provokes critical thinking. Why does this topic matter? How do we how does it affect the real patients? And what is the take home from this presentation when we do bedside rounding? Today, Keith is going to talk to you about a very interesting topic. Keith rounded with me for the Infectious Disease Fellowship, and he was very good, very thorough, and he has he's enthusiastic about seeing patients, and he wants to go into GI. So we decided this is a topic where there is some connection between ID and GI. So Keith, I will let you introduce yourself and talk.
All right, thank you for the intro, Dr. Gopal. My name is Keith Ngede. I'm a first year resident for internal medicine at Broward North in Pompano. I intend, so the end goal is to do GI. So I decided to do a topic in relation to that. I did rotate with Dr. Gopal about 3 to 4 weeks ago. I enjoyed my ID rotation. I learned some antibiotics and some of the indications for them, some of the bugs that those antibiotics will cover. And I think it was a good rotation. And I prepared this presentation in correlation with GI and infectious disease. I'll be talking about spontaneous bacterial peritonitis. Okay.
Right.
All right. So I'm going to share my screen. All right. All right. So can you see my screen, Dr. Gopal?
Yes, I can see it. Perfect.
All right. So this is an overview of spontaneous bacterial peritonitis, an infectious disease perspective. Again, presented by me and preceptor Dr. Gopal. So the objectives here, the learning objectives would be by the end of this presentation, you'll be able to hopefully describe the pathophysiology, microbiology, and diagnostic criteria for SBP, select appropriate empiric and culture-directed antibiotic therapy for SBP, and apply evidence-based SBP prophylaxis and adjunctive albumin therapy. So what is SBP? It's basically an infection of acidic fluid without an identifiable intra-abdominal surgical source. It occurs exclusively in patients with portal hypertension and ascites, commonly in decompensated cirrhosis. The epidemiology, about 1/3 of hospitalized cirrhotic patients with ascites, it will develop in them. In hospital mortality, about 20 to 40%. And then there's a 1-year recurrence without prophylaxis of 70%. So the pathophysiology of SBP, typically in cirrhotic patients, there'll be an immune dysfunction, so impaired innate and adaptive immunity. In cirrhosis, these patients cannot produce complements and immunoglobulins, so all of that decreases their immune system. Then there's what you call gut dysbiosis. So there's a loss of the good bacteria, the beneficial taxia. And then we do have pathobions that live within the organ system. And when there's gut dysbiosis, some of these pathogens, they grow out of their normal and they become infectious. Those would be Enterobacteriaceae and Enterococci. Um, this will increase intestinal permeability, loosening the tight junctions. Bacteria will translocate from the gut into the portal circulation, mesenteric lymph nodes. Um, and with this impaired hepatic reticular endothelial clearance and portosystemic shunting, the bacteria bypass liver filtration, and there'll be low acidic fluid opsonic activity. So basically what we talked about, opsonins like immunoglobulins and complements that typically bind to the bacteria, they're very low in acidic fluid. So that increases the risk for bacteria to proliferate in ascites and resulting in SBP. Other contributing external factors would be PPI overuse. Those typically would lower your acidity, which confers protection against bacteria. So that will make your pH increase and it will increase the risk of having a bacterial infection. We have alcohol, frailty, repeated hospitalization, again, puts you at risk for getting an infection, hospital acquired, and multiple antibiotic courses. The clinical presentation of SBP. So these patients already have ascites. So they would come in with fever, possible abdominal pain and tenderness, and sometimes altered mental status. And then some atypical presentations will also be worsening hepatic encephalopathy, new or worsening AKI, unexplained jaundice, hemodynamic instability without a clear source. So the key points: perform diagnostic paracentesis on all cirrhotic patients admitted emergently, even if asymptomatic. So how do you diagnose SBP? So the diagnostic criteria, acidic fluid with polymorphonuclear count, a PMN count, greater than 250. Okay, so the cultures may be positive or negative. Typically in SBP, it's typically monobacterial, so you typically see one bacterial species. And then you also have bacteriocytis. So bacteriocytis is similar to SBP, but the PMNs will be less than 250 with a positive culture. Some of these patients too may be asymptomatic. According to the AASLD and EASL guidelines, these are the liver associations in America and Europe. Uh, they do not believe you should treat if asymptomatic, okay, to repeat paracentesis to assess for progression. However, there was a study by OEETAL. They did this study in 2018 on 123 patients, and they found that among 26 untreated bacteriocytis patients who underwent repeat paracentesis, 42% were subsequently diagnosed with ongoing bacteriocytis or SBP. So according to their recommendation, they recommended that there should be a low threshold to start antibacterial therapy, even if the patients may not have symptoms. But if their PMNs are less than 250 and you're concerned for bacteriocytis, and the patients also have a severely advanced liver disease, there should be a low threshold to start antibiotics. Okay, so these are more findings from that study. The microbiology of that study saw that bacteriocytis showed a higher prevalence of gram-positive bacteria compared to SBP, which was mostly Enterobacteriaceae and Enterococci. The treatment, while some cases resolve spontaneously, initiation of empiric antibiotic is recommended for patients with bacteriocytis, irrespective of presence of symptoms, particularly in those with advanced cirrhosis, what we just talked about. And then you could see from this graph here, in bacteriocytes, typically more gram-positive, You see Staphylococcus and Streptococci. You do still see gram-negative, but it seemed, from what they found, Staphylococcus and Strep seem to be more common with bactericidis. Okay, the prognosis of bactericidis is poor, not solely dependent on the presence of symptoms, making it a critical early warning sign of severe liver disease. Okay. All right. So what tests can we perform for SBP? So we can perform a paracentesis. This you perform on all emergent admissions. Bedside inoculation of at least 10 ml into blood culture bottles. Then you do a cell count. So you get your CBC. You're looking for the cell count with differential. You get a PMN of greater than 250. This is from the paracentesis. And then acidic fluid culture as well. The bedside inoculation into aerobic and anaerobic blood cultures, blood culture bottles. You also get a blood culture, you obtain simultaneously, increases organism identification, but it is getting a positive or negative culture does not change the diagnosis of SBP. Also, acidic fluid protein. Low protein is typically seen with SBP. Typically would be total protein of less than 1 gram per deciliter. And then the gram stain, there'll be low sensitivity, but may guide early therapy. So microbiology of SBP, the gram negative is typically predominant, and you would see E. coli, which is the most common, Klebsiella pneumonia as well. And then gram-positive bacteria, we can see Streptococcus, Enterococcus, and Staph aureus, about 30% of it, but while 60% would be gram-negative. And then about the rest of the 5% would be fungi. And then that would be for community-acquired SBP. In nosocomial or healthcare-associated SBP, there's a shift towards gram-positive and MDR organisms, ESBL producing Enterobacteriaceae. About 30 to 66% of nosocomial isolates would be that. MRSA and VRE are emerging. And then there's also third-generation cephalosporin resistance that is noticed with 33.8% community versus 54.3% being nosocomial. So empiric antibiotic therapy for SBP, the first line therapy for community acquired that they got from outside before coming to the healthcare facility would treat with ceftriaxone or cefotaxime. And then the alternatives would be ciprofloxacin as well. And then for nosocomial versus healthcare associated SBP, Zosyn or piperacillin tazobactam, plus or minus vancomycin. And then if there's concern for VRE, you could add daptomycin. Nosocomial with sepsis or acute on chronic liver failure. These patients can get meropenem plus or minus daptomycin, which is superior to ceftazidime in randomized controlled trials for nosocomial SBP. MRSA risk factors as well. You could add vancomycin. That's patients who've had a prior infection or they've had a positive surveillance swab. Okay, and then we look at the response to treatment. So in 48 hours, you do a repeat paracentesis, which is recommended for all patients on empiric therapy. So to evaluate for treatment success, there'll be a decrease in the PMNs of greater than equal to 25% from baseline, and failure if the PMNs decrease of less than 25% from baseline. Now, if there's treatment failure, you could broaden antibiotic spectrum. So you can escalate to carbapenem plus or minus a glycopeptide like vancomycin. You could rule out secondary peritonitis. So secondary peritonitis is the infection came from an abdominal source. With SBP, it has to be without an abdominal source. So the CT scan would look for to rule out secondary peritonitis, would look for perforations and abscess, loculated fluid. Could be diverticulitis, could be appendicitis. And then if that is true, if that is the case for that patient, then it's likely not SBP. And then three, you could consider fungal peritonitis as well. So IV albumin is a life-saving adjunct. So this landmark randomized controlled trial was done in 1999. It's done among 126 patients with SBP. There was a group that received antibiotics versus a group that received albumin plus antibiotics, and found that the progression to AKI with these patients was 10% in patients who received albumin plus antibiotics versus antibiotics alone. Mortality was also higher in patients who received antibiotics alone. So there's a dosing protocol for adding IV albumin. So on day one, 1.5 grams per kilogram, and then day three, 1.0 grams per kilograms of IV albumin. And who benefits the most? Patients who have a serum bilirubin greater than 4, and patients with a baseline AKI of creatinine greater than 1 and BUN of greater than 30. Okay, and then the whole reasoning behind albumin is it counteracts the SBP-induced systemic vasodilation. So with all that inflammation going on, the systemic vasodilation would reduce the amount of perfusion going to the kidneys, and that could result in a pre-renal AKI, or we could also have an ATN if very severe. And so with albumin, it increases that oncotic pressure and would increase the likelihood of preventing an AKI. Okay, so for SBP prophylaxis, so we have primary prophylaxis, secondary prophylaxis. Secondary prophylaxis is typically after the first SBP, and the recommendation is norfloxacin daily, 400 milligrams daily, or ciprofloxacin, 500 milligrams daily, or TMP SMX. And this would be lifetime for prophylaxis. Now, depending on, providers, but typically the recommendation from the AA Liver Association recommends a lifetime prophylaxis, and also a recommendation to get evaluated for liver transplant. So the 1 year recurrence is about 20% with norfloxacin versus 68% placebo, and you continue until transplant or death. Also, for GI hemorrhage, the prophylaxis will be ceftriaxone until hemorrhage resolved, and then reduces infection, rebleeding, and mortality. And then for high-risk patients, primary prophylaxis, which some studies have said primary prophylaxis was not as beneficial and it did not improve survival. But some providers also want to be very careful with this patient. So norfloxacin or ciprofloxacin daily is recommended as well. And in patients with ascitic protein of 1.5 grams per deciliter plus renal dysfunction, or child PERC score of greater than 9 with bilirubin greater than 3. And so what are the key takeaways from what we just talked about? Paracentesis on every emergent admission, even without symptoms. PMN greater than 250 is diagnostic for SBP. You start antibiotics immediately. Stratify empiric therapy. So community acquired ceftriaxone versus nosocomial, broader coverage. IV albumin We've learned that it reduces the mortality from that previous study that was done in 1999, and then the landmark study, and then a repeat paracentesis at 48 hours to assess response after starting antibiotics. Then secondary prophylaxis after the first episode is lifelong until transplant, and antibiotic stewardship. You narrow when cultures return and shortest effective duration. Okay. Just like in any infection, antibiotic stewardship is very important with all these multi-drug resistant organisms that are developing. All right. So we're going to move on to questions. So question one, 58-year-old man with a history of alcohol-related cirrhosis, Child-Pugh C. He presents to the emergency department with diffuse abdominal pain, fever, and worsening abdominal distension over the past 2 days. He's confused and oriented only to person. Vital signs show heart rate 112 beats per minute, blood pressure 92/58, and respiratory rate 22 per minute. Physical exam reveals tense ascites, diffuse abdominal tenderness without rebound and shifting dullness. A diagnostic paracentesis is performed. Which of the following ascitic fluid results is most consistent with diagnosis of SBP? So we have 5 answers, and the correct answer is answer B. So why is B correct? SBP is diagnosed when acidic fluid is greater than 250. And it doesn't depend on cultures. We talked about that earlier. Answer B, there was a PMN greater than 400 with a single organism on culture and low protein. I'm sorry, answer A has the PMN below 250 with a Staph aureus, which is atypical for SBP. Answer C shows very high white count and PMN with high protein and polymicrobial culture. And we talked about being suspicious for secondary bacterial peritonitis. So in that case, the next step you would do is get a CT abdomen to rule out if the infection is from bowel perforation, from other diverticulitis, appendicitis, or an abscess somewhere. Okay. And then answer D, a PMN count below 250 and a negative culture, which does not meet diagnostic criteria for SBP. Answer E represents bactericitis, which is a positive culture, but the PMN is less than 250. Okay. Question 2, 55-year-old man with alcohol-related cirrhosis is hospitalized for an acute variceal hemorrhage. He undergoes successful endoscopic band ligation and is started on octreotide. He has no prior history of SBP. His acidic fluid protein from a paracentesis performed 2 months ago was 1.2 grams per deciliter. He is hemodynamically stable after resuscitation. Which of the following is most appropriate antibiotic prophylaxis strategy for this patient? We have A, ceftriaxone, B, norfloxacin, C, TMP, SMX, D, no antibiotic prophylaxis, E, ciprofloxacin. Okay, answer A. So patients with cirrhosis and acute GI hemorrhage are at risk for bacterial infections, including SBP, with infections rates of 25 to 65% without prophylaxis. So ceftriaxone is the answer, especially when there's a GI hemorrhage. Okay. So answer B, sorry, okay. Question 3. 52-year-old woman with alcohol-related cirrhosis, Child-Pugh B MELD score 18, was recently hospitalized for first episode of SBP, which was successfully treated with cefotaxime and IV albumin. She's now being discharged. She has moderate ascites managed with furosemide and spironolactone. Her serum creatinine is 1.0 and acidic fluid protein was 0.9. Which of the following is most appropriate long-term management strategy? A, no antibiotic prophylaxis and repeat paracentesis, only if symptoms occur. B, oral norfloxacin. C, oral ciprofloxacin. D, weekly therapeutic paracentesis. And E, oral rifaximin. And answer B. So after the first episode of SBP, the 1-year recurrence rate is approximately 40 to 70% without prophylaxis, and 1-year mortality after SBP is approximately 50 to 70%. These patients need indefinite secondary prophylaxis with oral norfloxacin. Okay. All right. Question 4. A 61-year-old man with NASH cirrhosis and large volume ascites presents with acute onset severe abdominal pain, fever, and rigors. On examination, the abdomen is rigid with diffuse rebound tenderness. Diagnostic paracentesis reveals a white count of 15,000, PMN of 12,000, glucose 18, protein 3.8, LDH 320, and gram stain shows mixed gram-negative rods and gram-positive cocci. Which of the following is the most appropriate next step in management? A, IV cefotaxime. B, repeat paracentesis in 48 hours. C, CT abdomen with IV contrast. D, oral rifaximin. And E, intravenous metronidazole. And the answer is C. Okay. This presentation is highly concerning for secondary bacterial peritonitis rather than SBP. And after that, when you suspect that, we get a CT abdomen with IV contrast and surgical consultation. And question 5, a 63-year-old woman with hepatitis C, cirrhosis, and refractory ascites is admitted with fever, abdominal pain, and automental status. Diagnostic paracentesis reveals an acidic fluid PMN of 620. Blood cultures are pending. She has no known drug allergies. Her serum creatinine is 1.1. In addition to empiric intravenous antibiotics, which of the following interventions has been shown to reduce mortality in this patient? A, oral norfloxacin. B, intravenous albumin. C, emergent large volume paracentesis with albumin replacement. D, intravenous pantoprazole. E, oral lactulose. And the answer is B. A landmark trial we talked about in 1999 demonstrated that intravenous albumin, in addition to the antibiotic cefotaxime, um, increases reduces the risk of progression to AKI, reduces in-hospital mortality, hepatorenal syndrome. It just has an overall benefit adding albumin to the antibiotic versus antibiotic alone. Okay, and just to go back on one of these things, in question 4, there's something called Reunion's criteria. So it can help distinguish between secondary peritonitis from SBP, meeting at least two of the following in ascitic fluid. There'll be a glucose of 50 grams per deciliter or greater, protein greater than 1 gram, and LDH greater than the upper limit of normal in this patient. So in SBP, typically these numbers would be there'll be a low glucose, sorry, there'll be a higher glucose, but then the protein would be low. LDH would also typically be uh, on the upper side. But the Runion's criteria would help distinguish SBP from it will help distinguish SBP from secondary bacterial peritonitis. All right. Thank you. And these are my references.
Okay, wonderful. It was very good. And this is a very important topic. We usually see these patients in the hospital with peritonitis, and I'm sure you have seen a bunch of them already. And
Mhm.
the magic number is 250 PMNs, and then we have to look at the clinical scenario. And bactericidis, I mean, it will be less than 250, but if they are symptomatic, then low threshold. But otherwise, we don't need to treat those patients. And then the treatment, like you talked about, I mean, ceftriaxone is good. And if we are thinking MDROs or hospital acquired, then you escalate them. So it was very good, very nice presentation. Good job. Thank
Thank
you, everyone, for joining.
thank you.